Welcome everyone to today's webinar, Leveraging ERAS Protocols During the COVID-19 Pandemic. I'm Erica Carbajal with Becker's Hospital Review, and on behalf of Becker's Healthcare, thank you so much for joining us today. Before we begin, I'm going to walk through just a few housekeeping instructions. So we will begin today's webinar with a presentation, and we will have time at the end of the hour for a question and answer session. And you can go ahead and submit any questions that you might have throughout the webinar by typing them into that Q&A box that you should see on your screen. Today's session is also being recorded, and it will be available after the event. You can use that same link that you used to log into today's webinar to access that recording. And we will have a series of poll questions during today's webinar, so you can go ahead and submit the answer that best applies to you directly on your screen in the slides box. Thank you in advance for your participation there. If at any time you don't see your slides moving, or if you have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help with that. With that, I'm pleased to welcome today's moderator, Michael Boylan. Michael is the Global Medical Affairs Manager for Cardinal Health. Thank you for leading today's important discussion. And Michael, I'll now turn the floor over to you.
Thank you very much. And again, I just want to say good afternoon to you all, and thank you for joining us on this webinar. As it was mentioned already, my name is Michael Boylan, Global Medical Affairs Manager for Cardinal Health, and I will be your moderator. So we're going to sort of kick off the webinar and move the slides forward now, and we'll go through the agenda. So obviously the welcomes have been done, and I'm going to shortly introduce the speakers. And after the introductions, there will be about a 5-minute presentation from each of the panelists. Keller will be overviewing enhanced recovery protocols. Athena Lendvay will be talking about implementing enhanced recovery protocols on a shoestring budget. And Dr. Beiermeister will be talking about enhanced recovery protocols from a surgeon's point of view. We're then going to have a short panel discussion, and then we're going to follow that up with a Q&A session. And as we all know, webinars are dependent on the content and also the questions that you ask about that content. So I really would encourage you to put any questions that you would have into the chat function, and we can answer them as we go along. So we're going to get going now, and we're going to ask you the first poll question. So if you could advance there. So my facility has implemented the enhanced recovery protocols. My facility has explored or is exploring implementing the enhanced recovery protocols. Is not interested in implementing the enhanced recovery protocols. I'm not sure. Or some other answers to the question. So if you can go ahead and start submitting your answers, and we'll take a couple of seconds to allow you to do that, and we can move on to the poll results in a moment. So if I can see lots of people answering. Wow. Okay. So there you go. There's our answers. So there's 57.4% of the attendees have implemented the enhanced recovery protocols, which is great. Maybe you can start sharing your experience with your colleagues in other hospitals, and then 23% are starting to explore or implemented the enhanced recovery protocols. I'm glad to see nobody's not interested in implementing them, and then not too sure, but maybe we can change your mind at the end of the webinar. So they're really interesting results straight from the get-go. So what I'm going to do next is I'm going to actually introduce our speakers to you. And we have 3 esteemed guests here today to talk about ERAS. Our first speaker is Tina Keller, and she is a senior clinical consultant with Cardinal Health, Clinical Operations, and has a bachelor's degree in nursing. Tina is also a certified OR nurse and a trauma nurse, and she has practiced extensively in the OR. She also has been a specialty coordinator for neurosurgery and orthospine, and was also an operations manager for surgical services. Our next speaker will be Athena Lendvay, who is a program coordinator at El Camino Health, a 2-campus community hospital in Silicon Valley, California. Athena has a bachelor's degree in nursing and is an oncology certified nurse with 20 years of experience in oncology, nursing education, and pain management. Athena is also passionate about the Enhanced Recovery Program and the benefits it can bring to her patients, and she was indeed pivotal in setting up the Enhanced Recovery Program at her hospital's facilities in California. And our final speaker, Dr. Beiermeister, is board certified in both general surgery and colon and rectal surgery. He's a fellow of the American College of Surgeons and of the American Society of Colon and Rectal Surgeons. He's the Chief of General Surgery at Scripps Memorial Hospital in Loyola and also serves as the Scripps Medical Director for the Enhanced Recovery After Surgery Program. I'm sure you'll agree that our panelist promises a great discussion on the protocol and the benefits that it can bring to your facility. So with that, we'll move on. And we'll ask Tina to start with her overview of Enhanced Recovery Protocols. Over to you, Tina.
Thanks, Michael. I became interested in enhanced recovery when I had to have surgery myself in a different hospital than where I had worked, and also helping my father in his surgical journey. So I've been a patient and a caregiver with enhanced recovery protocols. I'm really excited to speak about enhanced recovery protocols in these high-risk times of COVID-19. You might ask why you would want to implement right now with COVID, and I say, why would you not want to? In May of 2020, Forbes reported that more than 28 million elective surgeries had canceled or postponed during the first 12 weeks of the pandemic worldwide, which has created a huge backlog in surgical cases. And in December of 2020, Becker's reported that 106 hospitals were canceling elective surgeries in the U.S. again. There are also patients not seeking health care or avoiding treatment because of COVID-19, which results in sicker patients. All of this while national and regional economies are under maximum pressure. So what can we do to help patients feel more confident going into surgery? How can we help patients better prepare for their surgeries, and what steps can we take to improve our patients' postoperative outcomes? Slide. Now let's get started with a question. If a surgery is done well, then why are there bad outcomes? Danish surgeon Henrik Keller kept asking himself that very question. He was fascinated with and studied the effects of stressors on the human body. In the 1990s, he implemented multimodal strategies to improve the outcomes of his colorectal surgical patients. He had tried many different scenarios that had evidence-based outcomes, and he would add new ones as they worked to improve postoperative results. In 1997, he released his findings, and as one measure of success, he reported that his patients were being discharged 2 days post-op as opposed to the average of 7 to 10 days at the time in Europe. The Enhanced Recovery After Surgery Society was formed in 2001. It's a nonprofit organization, and ERAS's mission is to develop perioperative care pathways and improve recovery through research, education, audit, and implementation of evidence-based best practice. The ERAS Society has published a wide range of publications regarding protocols and guidelines for enhanced recovery after surgery. The protocols have expanded to include most major types of surgery, including C-sections, total joints, thoracic, cardiovascular, GYN, urology, plastics, and the list continues to keep growing. So exactly what are these protocols? Enhanced recovery protocols are designed to help decrease postoperative complications after surgery. More specifically, they are multimodal perioperative care pathways designed to achieve early recovery after surgical procedures by maintaining preoperative organ function and reducing the profound stress response to surgery. Let's look at some of the details of enhanced recovery protocols. Next. The protocols are divided into 3 phases: preoperative, intraoperative, and postoperative. But in reality, they begin once a patient is scheduled for surgery and can continue even once the patient is at home still recovering. Key principles for each phase include, in the pre-op phase, optimizing the health of the patient beforehand with things like smoking and alcohol cessation, exercise, and preoperative nutrition. Preoperative counseling, which includes patient and family education. Minimal preoperative fasting and including a carb-loading beverage up to 2 hours preoperatively. Antibiotic prophylaxis and thromboembolism prophylaxis. During the intraoperative stage, the goals include using minimally invasive surgical technique when at all possible, utilizing multimodal analgesia, prescribing directed fluid therapy, postoperative nausea and vomiting prophylaxis, intraoperative drains and the use of NG tubes being limited as much as possible in maintaining normothermia. During the postoperative phase, multimodal pain control with NSAIDs, Tylenol, and epidurals, avoiding salt and water overload. Early mobilization is recommended in getting the patient up and moving and performing activities as soon as the same day of surgery. Early oral nutrition with a return to a normal diet as early as the same day of surgery. Ensuring good handoff communication. Auditing of compliance and outcomes. Next. Despite the proven benefits of decreased complications, decreased length of stay, and a cost savings of an estimated $5,000 to $8,000 per case, enhanced recovery is still not mainstream practice, even though the first guidelines from the ERAS Society were published over 15 years ago. We've identified 4 key challenges for this, and that's lack of internal buy-in, a lack of patient and or staff compliance, partial adoption of a program or working in silos, and auditing with lack thereof. They're not tracking the success and the data. So with these challenges in mind, how do you work to combat them? The first critical step is collaboration, being clear on the desired outcomes of the program, identifying the key stakeholders and champions, including a nutrition champion, decision makers, and being clear on the needed investment for success. All of these things help support the path to internal buy-in, reducing silos and driving staff and patient compliance. Next would be coordination. Many hospitals begin implementing with one service line and based on results expand into others. There have been instances when one department was executing enhanced recovery protocols and counterparts in other departments and cross-functional team members weren't even aware of that happening. In order to drive consistent coordination, many hospitals have hired enhanced recovery coordinators to help connect the dots, including consolidating products, tactics, and communication. Communication either makes or breaks your program's success. Ensuring there is ongoing education of both staff and patients throughout the program, with execution being key, and further creating clear methods to examine program progress, including tracking what's working and what's not working, also known as auditing. Focusing on collaboration, coordination, and communication is key to implementing any program. That's what it's all about, optimizing outcomes for patients. And to do that, it's a combined effort between patients, surgeons, hospital staff, leaders, and let's not forget about third-party partners like Cardinal Health. Cardinal can partner with your institution to help support the protocols you put into place by providing the best product bundle per service line and coordinate how to get the product to the patient, either through the hospital, to hand out, or directly to the patient's home. Now back to you, Mike.
Thank you very much, Tina. That was a really interesting overview of the enhanced recovery protocols. Most appreciated. Thank you. Our next speaker is Athena Lendvay, and she is going to be talking about implementing the enhanced recovery protocols on a shoestring budget. So, Athena, over to you.
All right. Thank you, Michael. So you can move to the next slide. So my story is, back in 2016, a GYN oncologist attended a conference where he saw a presentation on enhanced recovery after surgery. When he got back, he came up to me and said, I want to do ERAS. My response at the time was, you want to do what now? Because I'd never heard of it. And then the next words out of his mouth were things like, it's no big deal, it's a pilot project, and then even more telling, I don't want to go to a lot of meetings. And at first, I believed him that it wasn't a big deal. But then I read a research article about enhanced recovery after surgery, and another, and I realized as I learned about the frankly amazing outcomes for things like decreased opioid use, post-op applications, and length of stay, that this actually was a very big deal indeed. Next slide. Even though I had no budget for a large project like this, I thought, if I can actually improve patient outcomes this much, how could I not try to make it happen? So I went to my boss and obtained permission to spend time working on it, but of course it was in addition to my regular work. Then over the next 21 months, I worked on it intermittently in between my other job duties. I started initially by comparing our existing pre- and post-op order sets with the ERAS Society recommendations and figuring out where our gaps were. I also spent a lot of time looking for examples of patient education materials about enhanced recovery from other hospitals to think about ways we could develop our own patient education. And throughout this time, I consulted with our in-house experts on elements of the protocol, as well as developed staff education materials and classes. So then, after a year and 9 months of working on this as a side project, we finally went live with an enhanced recovery pathway for GYN oncology, and then I worked on collecting outcome data. Now, here's where data collection is key at this point in the process. Although it's certainly very helpful to show research articles to upper administration that highlight all of the great outcomes for enhanced recovery, nothing has more impact than data from your own institution. For example, a common outcome of enhanced recovery is decreased opioid use. And honestly, we would have been happy achieving just a 10% decrease. So when I completed the calculations showing that we achieved a 58% decrease in opioid use, I just about fell out of my chair. Even though there's a lot of research that shows similar outcomes, seeing what a difference it can make with your own patients feels much more real. So when I was able to present that data, including a 62% decrease in antiemetic use and a 13% decrease in length of stay, which led to an estimated annual cost savings of $200,000, then, as you can imagine, I had their attention. Then they were much more willing to put resources into refining and expanding the program. So we implemented an enhanced recovery committee in 2019, and in the year following developed and implemented protocols for 3 specialties: GYN, C-sections, and orthopedic hip and knee. Next slide. Now, I've been to several enhanced recovery conferences, and a common theme I hear at them is that in order to implement a program like this, you need to put together a large multidisciplinary committee, and you need to meet every other week for an entire year with lots of money and resources before you can make it happen. And I agree that is absolutely the best way to do it if you can. But if that surgeon and I had waited for all of that to happen, then it's pretty likely we still wouldn't have changed a single order set by now. Although there are standard elements of an enhanced recovery protocols, it's not quite a one-size-fits-all, and every hospital and even specialties have to determine what will work best for them. If you have a multidisciplinary committee to turn to, that's great, but if you don't, just figure out who your in-house experts are. Aside from input from the surgeons and anesthesiologists, there were many other experts I consulted with at my hospital to help me develop our protocol. So, for example, when I was researching post-op diets, I met with dietary. When I was working on medication dosing for things like Neurontin and other multimodals, I consulted with our geriatric specialists in pharmacy. I spoke with diabetic educators about carbohydrate dosing and glucose control. The list goes on. And I took their input and circled back to the surgeon to collaborate on putting together an enhanced recovery pathway that resulted in really outstanding outcomes for our patients. So, to summarize, implementing an enhanced recovery after surgery pathway is absolutely possible without a large budget. It may take longer and more work in some ways, but don't let that stop you from implementing best practice for your patients.
Thank you very much, Athena. That was really interesting. And I've been involved in ERAS for a while now. And each time I hear statistics like that, I'm just blown away, just like you were blown off your chair. So thank you very much for sharing your insights on that. Next, I'm going to hand over to Dr. Keith Beiermeister, and he is going to tell us about enhanced recovery protocols from the surgeon's point of view. So Dr. Beiermeister, over to you.
Thanks, Michael. I appreciate the intro, and I want to thank Tina and Athena for giving a great initial overview of ERAS. I just wanted to start with our story here at Scripps, how we got started, and then, on my last slide, I'll go into some of the specifics about, a surgeon's point of view and how that can be beneficial. So Scripps Health is a 5-hospital, not-for-profit, non-academic system in San Diego with roughly 1,400 beds. We're not a big academic powerhouse. We don't have unending resources, and I think that's the value of our story, is that this can be done at a regular hospital that doesn't have all the academic backing that some of this research comes out of. So we started our formal ERAS program in colorectal in March of 2017, but I was actually informally, along with my partner, collecting data well before that, and we sort of leveraged that information and that data to form our formal ERAS program, which was developed and vetted by a system-wide ERAS committee. We initially collected length of stay, opiate use, SSI, and readmission, which were the metrics we thought was valuable for our institution, and that was collected via chart review of our legacy EMR from late 2016 until early 2017, and we based that on patients that would have been eligible for ERAS should we have an ERAS program at that time. With our initial 6-month collection of data, we saw dramatic results similar to what Athena had seen. We saw a 50% decrease in length of stay. Opiates were decreased by roughly 2/3, along with statistically significant decreases in SSIs and readmissions. And then 2018 came along, and our hospital transitioned to a new electronic medical record, and unfortunately at that time we lost all of our ability to audit compliance and tie metrics to the appropriate patient population. Now, that's not to say that in 2018 we weren't doing ERAS, but we weren't capturing our data, and I think it's been stressed throughout this presentation about data collection and auditing, especially in your own institution. So that was a bit of a hiccup for us. So next slide. So we worked throughout 2018 to develop an ERAS identifier within Epic, and finally, again, starting in early 2019, we were able to recapture those patients. Now, if you look at the figure on the right of this slide, between the second and third bar, you'll see that's where 2018 is missing. And that's the data that we unfortunately lost. But the good thing is that when we were able to recapture this data, we showed consistent improvement in our numbers, and that's persisted throughout mid-2020 and beyond, despite the pandemic and all the things that we've all had to deal with. And then in addition, based upon this data that we collected in our colorectal patient population, we were able to leverage that and phased in ERAS protocols in gynecology, gynecologic oncology, bariatric surgery, and most recently in October of last year, cardiac surgery. We continue to work on protocols in multiple service lines. Currently, we're actively developing protocols in breast and spine with potential for urology and joint replacement after that. So that's our story. Next slide. Just to point out a few things I think that were a big learning curve for us along the way. You know, it's not just about developing these, but it's constant work, and it's constant auditing, and it's you know, it's having a structured protocol that works for your institution with active and ongoing participation in all levels. So you can't just claim success here. These numbers and results just don't happen on their own. It's constant work, and it's, you know, auditing the protocols and making adjustments as needed. I feel like administrative buy-in is essential, and you can say that, but then the next obvious question is, well, how do you do that? And I think when you start showing numbers like we saw and like Athena saw, and it becomes a dollars and cents issue, I think your administration will be behind you 100% once they see those numbers. So you might need to have a little bit of a you know, a loosely created program, follow some numbers, audit some numbers, and show them that this stuff works. And again, it's valuable when you show them that it works at your institution and not just a paper from some random hospital somewhere else. You know, for me, I like to liken ERAS to this diffusion of innovation, and you know, I think you're always going to have some people who resist change in the same way that people will resist adoption of new technology. But I think you need to focus on the people that you know you can get on your side. You're never going to get that last 15%, but if you have a participation of 80 to 90%, which is traditionally what we've had throughout our protocol, you're going to see these results and you're going to make, a big impact at your hospital. Auditing is key, as we've said multiple times along the way. And again, I'm sure we'll talk about this with some of the questions, but, ERAS is just a natural fit for what we're dealing with right now. It saves the hospital money. It takes a stress off of the staffing and resource utilization, and those are all the things that we need for our hospitals right now. So that's my perspective, and I think we'd all be more than willing and happy to answer any questions that have been coming through throughout the presentation. So, Michael, I'll turn it back over to you.
Thank you, Dr. Beiermeister. Most appreciated. So we've heard from our panelists, and I'm sure you'll agree it was very informative. So what we're going to do now is we're going to move on to the questions and answer session. First, panel questions and discussion. So I'm going to kick it off with a question that we have here, and it's what are the benefits of leveraging enhanced recovery protocols during COVID-19? So I'll open that up to the panel, and whoever wants to jump in and give us an answer, go for it. Thank you.
I can start.
This is either way. Go ahead, Tina.
Okay, I was just going to say that research has shown consistently that by adopting enhanced recovery protocols, you decrease stressors, you decrease complications, and you have better outcomes, which increases the recovery time of a patient, which then decreases length of stay. So it's better for the patients, it increases patient satisfaction, it's better for the hospitals because the cost of care goes down, and it also allows you to move through a backlog of surgical cases if you happen to have them. Go ahead, Athena.
Hi.
Yeah, no, I absolutely agree. I actually had the unique experience. We were close to the verge of launching some of our current ERAS protocols for like orthopedic hip and knee, for example, right kind of when the first COVID spike hit and our hospital beds were filling up with COVID patients. And at the time, I was like, oh, well, of course we're going to pause all this, right? And the director of quality actually looked at me as like, well, why? This is the perfect time to keep going. We need to get these surgical patients better, faster, and back at home sooner where they can do their best recovery. So it's a win-win all around. And I'm like, right. Yes, of course. Absolutely, you're right. So we continued pushing forward even through all this to the benefit of everyone.
Yeah, I think I agree with both Tina and Athena. I touched on it in my last comments there. It's just, this is taking a lot of stress off your system. You're getting people out earlier. You're freeing up staff. I don't know about everybody else, but for us, especially in this second wave, staffing has been the real issue. So, obviously when you're getting people in and out quicker, patients are happier. They're going home. They're having less complications. And it's not just that you're pushing these patients out. They're not coming back either. And that's why we really pushed the tracking of readmissions because, it's one thing to just say, oh, we're moving these people out and, but then they're coming back through the ER 2 or 3 days later. This is taking a huge stress off the system, and the people are happy and they're recovering better and they're not coming back.
Great. Thank you very much, Dr. Beiermeister and panel for your responses to that question. I have a question coming in here from Daniel Guest, and he's asking, what recommendations do you have to help get internal buy-in when implementing enhanced recovery protocols? So I'll ask Athena to answer that initially, and then we can get Dr. Beiermeister and Tina.
I'm sorry, was it Athena or Tina first?
Athena, apologies, yeah.
Okay.
Yes, please, Tina.
We have very similar sounding names. Okay, so for me, so for me starting out, it was I had a leg up because I had a surgeon approach me. I didn't have to convince him, he had to convince me, and so that became obviously a little bit easier. So as I expanded, though, obviously when I'm talking to entire other service lines, I definitely got pushback. What helps is if you get a surgeon that's well respected with a high volume, who is also understands the benefits, and they can kind of help you lead the charge, as well as anesthesiology, because anesthesiology is the group that sees all the doctors and talks to them during cases. And getting them on board, they can help casually just bring it up during surgery. It's like, oh, hey, we're working on this. What do you think? That sort of thing. And the more other respected physicians that other physicians hear it from, the more it helps them kind of get used to the idea and slowly buy in.
Thanks, Athena.
I agree with
Appreciate
you,
that.
Athena. Yeah, I totally agree with you. I think, I hate to say it, Dr. Beiermeister, close your ears, but I think surgeons are a little competitive. And I think if you are able to start with one surgeon even in a specialty, and then they start sharing their results, it usually tends to be, well, I want those results as well. And so I think that drives a little bit. And I also fall back on those 3 C's of communicating, collaborating, and coordinating, finding your champions. You not only need a surgeon champion, but you definitely need an anesthesia champion. You definitely need a nurse champion like Athena, and your surgeon champion to start with, and then spread out from there. So you need to coordinate, collaborate, communicate, and I'll even add a 4th C of commitment, because it is a commitment to start these programs. It's not something in the short term, it's, long term, and you have to have administrative buy-in to accomplish all that. Dr. Beiermeister, do you have anything?
Yeah, I mean, I agree with everything that's been said. I mean, I think, coming from the surgeon perspective, it certainly helps when you get, buy-in from that level. But I think, that when the message is communicated, I think directly from the surgeon or the anesthesiologist to the staff, is when you really get the buy-in and you start seeing the impact of the protocols. It's not something that we can just make an announcement or send out an email. The best thing that I ever did when we instituted our first protocol in colorectal was set up a dinner with our nurses, and I just went through, ERAS 101, just basic stuff, and what we're doing with this. So when they hear that, your patients are there's all these changes in how you're taking care of your patients, and no one thing that's crazy, but just, as a protocol, and what impact that can have. And then when they start seeing the patients going home 2, 3, 4 days earlier than they normally would, when, there's other people that aren't doing it, and, they're seeing the old results, that's where you get the huge impact, I think.
That's very, very insightful, Dr. Beiermeister. Indeed, when you have 2 people looking at the situation, their patients going home earlier, you're just going to want to get on the train and start introducing ERAS. So I have another question for the panel, and it's from Daniela Terrizzi, and her question is, how does the ERAS coordinator work day to day? So I think, Athena, this is definitely in your wheelhouse, so we can kick off with you if you don't mind.
Certainly. So I'm not a full-time just ERAS program coordinator, so it's been folded into my other job duties. So I can't really answer as to what a full-time ERAS coordinator would do, but I can tell you, I could tell you at this point in the game, when we are still developing and launching protocols per service line, it could easily be a full-time job. I spend a lot of time, say when I very first start with a protocol, I spend a lot of time meeting with the surgeons from that service line. I can do a lot of work with comparing the current pre-op and post-op and intra-op protocols and order sets with what's recommended by the ERAS Society and other similar organizations. And then I meet with the surgeon and say, okay, so these are the gaps that I see. What is your input? And I have to kind of go to as many surgeons as are willing to see me to try to slowly increase buy-in, and to as many committees that they attend to slowly increase buy-in. And then work with the other, again, like I talked about, I still end up meeting with a lot of the other experts in my organization, because some of these things maybe with multimodals may vary a little bit from service line to service line. And then data traction, data compliance. Do the order sets need to be tweaked after go live? Who's complaining about what part, and is it something that everybody's unhappy with or just one person, and how do we soothe those ruffled feathers? What kind of gaps do we have in nursing? Do I need to kind of reach out to them and talk to them? Are patients not understanding why they need to get up and out of bed, and how can we figure out how to tackle that? It's a continual process that always needs kind of looking at, refixing, retweaking, and sometimes there's even still data coming in. There's some new data that came in recently about chewing gum, whether or not we wanted to keep that in our protocol or not. There's some more controversy recently about Neurontin, so I have to kind of spend a lot of time sort of looking into that and tracking that down. There's just, I mean, I can't even say, there's just so much to do. When we are fully alive and integrated with ERAS someday, will there be less for me to do? Maybe, but there's always I think, room for process improvement in any organization.
Great, thank you, Athena. Any other panelists would like to contribute to the question? Okay. So we have a very interesting question here, and I suppose it's a very important part of enhanced recovery protocol, and we did touch upon it in the presentations. And the question is, how does auditing work? Is it a weekly review of certain outcomes? Does it focus on process metrics that impact various outcomes? Dr. Beiermeister, would you like to take that question initially?
Well, I can tell you what we do. We have a weekly meeting with myself and my coordinator and a few other people who help us. Again, similar to Athena, our coordinator is not, and ERAS is not the only thing that she does. She wears multiple hats, so it is a lot, and it's a big commitment. I think, my personal feeling is, meeting when you have, 4 or 5 protocols going, especially, and it's an unending, it's unending data that you need to stay on top of. I think each service line sort of, in my opinion, needs to have its own champion. I mean, certainly I can speak to what is appropriate in colorectal surgery, but as we went out to bariatric and gyn-onc and especially cardiac was one of the biggest ones that we tackled. You need to have champions within each service line and continue to communicate with them. Now, you probably don't need to meet with them every week, but I would say at least quarterly to kind of review the data and reassess your order sets and how things are going, and look at participation, and is there anything we can do to improve buy-in. So it's a never-ending process, but every institution is going to have their own process that works for them. That's what works for us here, and I'm of the opinion that I'd rather be on top of this stuff, then we put all this work in and on the front end, and we want to make sure we're having continued success.
Great. Thanks for that, Dr. Beiermeister. And I suppose there's a follow-on question, really, and it's something you mentioned earlier, Dr. Beiermeister. And the question is, a comment first. We have had ERAS in place for a couple of years now, and I'm interested to know more about how you were able to get data out of EPIC. This is our current challenge. I know you sort of touched upon it earlier on. So I'll let you take that one if you don't mind.
Well, I don't know if we have enough time left in the webinar to really go through that, but certainly I could connect with people offline and walk them through that. I had mentioned that we developed an ERAS identifier in EPIC, and those people that have EPIC will know what I'm talking about. Those people that don't will have no idea. But basically what happens is in EPIC is there's phases of care. And so it's not that we didn't know which patients were going to be ERAS, but as soon as they got into their different phases of care throughout their hospital stay, they were lost in the system and couldn't be tracked. So we basically worked with our EPIC team on our own and developed within our EPIC. And each EPIC, while it's all EPIC and has the same basic framework, every institution has a little different version of EPIC. But what we did, we went through multiple different scenarios and ultimately settled on an identifier that was built into our ERAS order sets. So we used that order set as the basis for every protocol that we start from now on, and we include that ERAS identifier. And what that does is that allows us to track the patients throughout the different phases of care so they're not lost in their hospital visit. Now, the technical way that that's done, I could certainly connect people with our EPIC people. I mean, again, it's not something that's going to be solved on this webinar, but that's the basic framework of what we settled on. And with that, we are able to track these patients and get the data that we showed.
Great, thank you for that. Do any of the other panelists want to comment on that? Do you have any difficulties tracing your patients with your computer systems? Okay.
This is
Good
Athena. Our process is fairly similar to Dr. Beiermeister. We do track patients by the ERAS order sets that are used, and you do need to have an analyst within your EPIC organization to be able to write the scripts for that and work closely with them on that. And it takes a lot of back and forth to get the data right.
And another alternative, real quick, I don't want to spend too much more time on this, but through the ERAS Society, there is a separate data recording system that they have called EIAS, and that's, we didn't choose to go that route because we wanted to keep it within EPIC, and, we felt that there was a way to figure out how to do this in EPIC and leverage the technology that we already had, as opposed to bringing in more technology that would require manual data input from EPIC into EIAS, and we didn't feel like that was the most efficient way to do this. But that is an option.
Thank you. Great. Thank you for your insights there. I have another question here, and it's about getting down to this specialty level. Are there any specific ERAS elements specific to or not applicable to total joint procedures? Does anybody want to take that one?
Yeah, this is Athena. I could talk a little bit about that because I just did total joints recently. So there's some things that are controversial, well, not controversial. So the carbohydrate drink, for example, the data doesn't really seem to indicate that the carbohydrate drink in a total joints is necessarily of huge benefit just because of the type of surgery it is. However, because it gets complicated to kind of tell some random portion of your patient population, oh, you don't get the carb drink, but you do, and to try to have the pre-op department keep that straight as long as everybody else, we did decide to just to have every surgical patient that gets an incision just to have a carb drink all across the board. So that's one example. There's a lot of controversy post-op with total joints as to whether or not you do standard nonsteroidals afterwards, and there's still some disagreements among physicians as whether you should do nonsteroidals around the clock after, even though it is recommended. So to some of that, because I am aware that there's controversy there, I just sort of have that as an option in the order set, but I don't push too hard if some surgeons aren't uncomfortable with it, because I do have to recognize this is their patients, right, not mine, and they have to feel comfortable with how they're doing it. And then there's a few other maybe little things, but I think for total joints, mostly across the board, it's the basic ERAS elements are pretty standard. The ERAS Society does have a total joint standard that they put out, I think, about a year and a half ago. So I definitely recommend looking at that.
Great. Thank you very much for that, Athena. Another question here, and it's about our patients. And the question is, how are you educating patients on doing their part of the ERAS pathways, like hydration protocols, walking post-operatively, etc.? So yeah, I'll open that to the entire panel because this is a really interesting question. We've been focusing on our side of it, but it's good to have a little bit of a perspective on the patient side and what we're doing to educate them about the protocol. So I'll open it up to the panel.
I can start. I as a patient, when I was having surgery, I was given all the instructions at the surgeon's office with a booklet that spelled everything out for me as to what to do and when to do it, what to expect. That's kind of where I started researching this because I'd had surgery at other hospitals and had never encountered anything like that. And I tell you, I was completely satisfied and grateful that it was all spelled out for me and true to form, everything that I read about in the booklet that I was provided and in the hospital, it's like everything was predictable and I knew what to expect. So it was great.
That's a really interesting perspective, Tina, personal experience. Go ahead, Tina. Can you answer?
Yeah, so this is Athena. So we do, in our pre-op kit that we give to patient, we have a 2-page handout that spells out their eating and drinking and bathing instructions, as well as a brief overview on what enhanced recovery after surgery is. And I really try to emphasize with them that of the elements, like you talked about, post-op walking, hydration protocols, the things that they need to do to be involved in their recovery, as opposed to sort of the old school thinking is like, oh, I'm sick, I'm just going to lie in bed all day, when we, of course, we as professionals know that's the worst thing they can do. So I try to really emphasize that of what they need to do to participate in their recovery. It's also very key to circle around and personally talk with especially your high volume surgeons' offices that are sending patients, because for the most part, if not all the time, they're receiving their preliminary pre-op education in the office, usually by maybe a nurse, maybe a medical assistant, maybe the surgeon, and circling with them and talking to them. These are the expectations that you really need to set right in the office so that they've kind of come in, hopefully, already a little bit prepared. We also have a booklet as well that we give them.
Great, thank you, Athena. Dr. Beiermeister?
Yeah, I mean, I would agree with both Athena and Tina. I mean, I think setting appropriate expectations is one of the most unrecognized parts of ERAS, and really it might be the biggest change for your institution, because you can develop an order set and you can say that you're going to do this, but having the patient actively participate in your protocol and having that conversation with them in the office the first time you meet them, when it comes to how your pain is going to be controlled, what your expectations are, the fact that you're going to be eating right away, that you're going to be up and moving on the day of surgery. These are not things that most patients come into your office and think that's what's going to happen, because everybody's got a story of someone that they know that had surgery and was in the hospital for a week and had this little button that they pushed and gave them pain medication anytime they wanted, and we talk about pain as a bad thing. I always tell patients pain is a good thing, and you should expect that you're going to have pain, and our goal is to control your pain, but it's not to eliminate your pain. So setting expectations like that, I think, is huge in really getting success in your ERAS program. And then also obviously having things like pamphlets and things that you can give them to go with to reinforce those expectations. We're in the late phases of development of a preoperative app where patients will get reminders on their phone through their My Scripps chart that will, tell them, it's time to drink your clear fast, and, these are the expectations, and, patients that are getting an ostomy, here's some ostomy education. All of these things are kind of starting about 2 weeks before, being pinged on their phone and giving them reminders here and there. The more people hear about it, the more they're willing to participate, and the more success you'll have with your protocol.
Great, thank you. Thanks for that answer. And we move on. I just have to say we have maybe about 60 or 70 questions come in, and we won't get to them all in this short webinar. But I suppose that's an indication of how interested people are in implementing the ERAS protocol. So we've got 10 minutes left, so I'm going to kick on with another few questions. And I think this is quite an interesting question coming up. How would you suggest we go about implementing the ERAS protocol within a large healthcare system, i.e. 10 hospitals scattered over the state? So I'll open that up to the panel if they want to jump in with their own particular experiences, and even suggestions about implementing it in this large system.
So, my suggestion would be, I think, you might want to consider starting small. We're not a 10 hospital system or a 5 hospital system. I wouldn't say we're probably more of a medium-sized system, but most of where we started was, I'm only at one of those hospitals, and so most of where we started was at my site. And you have to develop a protocol that works for you. Get started, even if it's informal. Collect your data and move on from there. So, but within a system that large, you might want to consider just focusing on 1 or 2 of the institutions where your champions are predominantly, and then leverage that data and that information to go system wide.
Great, thank you for that, Dr. Beiermeister. Athena, would you have anything to add?
I'm not Dr. Beiermeister. I'm just in a 2-campus system, but everything that he says makes total sense from what I've heard at ERAS conferences.
Thanks, Athena. And Tina, would you have an input in this? I'm sure you've helped some institutions implement it, large institutions. Would you have any input on that?
Not really anything else to add other than starting with one surgery type and then spreading it out. 1 hospital, 2 hospitals was great, and then expanding from there. I think that's where a coordinator really comes in handy to ensure that all across the system, a large system, the same information is being shared and coordinated. So that's where that kind of job position would really, really come in handy.
Okay, thank you very much. And another question here. Looking back after implementing the protocol in your systems, is there anything you would have done differently in how you implemented it? The troubleshooting, I think. Either Dr. Beiermeister or Athena?
I don't think I would do much differently. We started small. We started with 1 protocol. We had our hiccups along the way, but I think that those were very unique to our system because of the Epic issue. I don't have any particular regrets along the way. We've had really nothing but positive results. I think you just need to work on getting a few people who are passionate about this to get appropriate buy-in, and then start spreading the word.
Thank you. Thanks for that. And we'll crack on with a really important question here. It's come up a couple of times about the carb drink. And it's basically, how many carb drinks are you giving each patient? And is there a recommendation around 1 or 2 carbohydrate drinks? So I'll open that up to Athena and Dr. Beiermeister and Tina.
Yeah, this is Athena. I can totally tackle that one because I've put so much thought into this. So to recap, for those of you who may not be aware of it, the original ERAS Society recommendations were to have patients drink a carbohydrate drink the night before surgery of 100 grams and the morning of surgery of 50 grams. So the Ollie Lundquist, which was the surgeon in Denmark, I believe, who did all of the initial research on this, that's what he came up with. And that's what he came up with at the era that everybody was having all of their patients do bowel preps. Now, in Europe in particular, bowel preps have very strongly fallen out of favor in ERAS protocols. Here in the States, bowel preps are still very controversial. I'm sure Dr. Beiermeister is very well aware of this. And so Dr. Lundquist, the original researcher, has dropped his recommendation for the nighttime carb drink because in his world, nobody does the bowel preps anymore. So he says that if you're not doing bowel preps and you're not losing all of those electrolytes, you don't need the nighttime carb drink. You just need the morning one. So then that begs the question, what do you do here, right? I do see in my institution where I'm seeing at least less and less carbohydrate bowel preps being done before surgery. So we're kind of moving very, very slowly in kind of the European direction. And we decided for simplicity to go ahead and just do the morning carb drink of 50 grams and not do the evening carb drink. So that's the way we've done it, and that's kind of the way I'm a little bit seeing more and more hospitals across the United States do it as well. So Dr. Beiermeister, you want to jump in on your experience?
Yeah, so again, this is a whole nother webinar, but, when we talk about bowel preps and, whether it's good or bad, I think, the data, the pendulum swings back and forth year to year. I do currently bowel prep my patients, but I think the key is you should never do mechanical bowel prep alone, but the data supports antibiotic bowel prep in addition to mechanical bowel prep. So what I still do follow the original recommendations, and we provide our patients with 3 drinks. So they get that 100 grams the night before and 50 2 hours before, but my patients are being prepped. So it might be, it's a very kind of layered question, I guess, in that how you manage your patients, but that's how I do it here.
Okay, thank you for that, Dr. Beiermeister.
Oh, and let me,
this
is Athena. Just one more quick, I just really have to jump in on this because it's so near and dear to my heart. I absolutely 1,000% agree. The data does strongly show that if you're going to do mechanical bowel prep, you really need to add antibiotic bowel prep with it.
Thanks for that, Tina. So we're nearly up on time. I can't believe the hour has gone by so quickly. It's been really interesting. So in the last minute, I'd like maybe 20 seconds final thoughts from the panel, if that'll be okay.
This is Tina. I'll simply say that, no matter what solution you're looking to fill, Cardinal Health can create packs or have standard packs to help you along your enhanced recovery journey.
This is
Great.
Athena.
Thank you, Tina.
Yeah, this is Athena. I guess what I would love to close with is that I've been a nurse for 20 years, and I have to just honestly say that in working on this project, Enhanced Recovery After Surgery, with its amazing outcomes, has been really one of the most meaningful things I've ever done in my nursing career, and I'm just so very excited about it.
Great. Dr. Beiermeister, any final thoughts?
Yeah, I mean, I first of all, I feel bad that we've only gotten to a small fraction of the questions. I wonder if there's any way, we can put out our information so people can ask these questions offline. But yeah, I mean, I think the key is to just get started and not overcomplicate this. Find something that works for your institution. I think one of the major things that I struggled with as we got up and running was I relied too much on what other people were doing. The basic framework that Tina gave in the initial part of the talk is that's your starting point, and you just need to figure out what works for you and not worry about what other people are doing. You know, obviously there's certain components that pretty much define ERAS, and we, you know, those need to be included, and I think most people know what those are. But, you know, the little tweaks here and there, I wouldn't overthink it. I would, you know, just do what is going to be simplest and works for your institution, and then move forward, and I promise you'll start seeing results.
Great, thank you very much. And in my closing remarks, I just want to say how informative the webinar is. You guys did a really, really good job. And it would be remiss of me if I didn't sincerely thank Kendra Hill, who was the driving force behind this webinar. She did a stellar job in organising it all. So thank you very much, Kendra. Most appreciated. And I'd just like to thank everybody for joining us this evening. Thank you so much, and we wish you the best of luck in implementing the ERAS protocol. Of course, we will get to the questions and try to get to the responses out to you in the not too distant future. And with that, thank you very much. Have a great day.
Thank you so much. That is all the time we have for today. I want to thank our terrific speakers for an excellent presentation and Cardinal Health for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you so much again for joining us, and we hope you have a wonderful afternoon.